Hello everyone and welcome back to my channel. In today's video we're going to talk about the airways anatomy. Airways anatomy is really important because as future anesthetic providers we need to be expert at this. We need to understand every single part. We need to know the muscle part, the innervation, the vascularization, because that is what we're going to be doing every single day at work. So without further ado, I am going to divide our airways into the upper airway and the lower airway, and we're going to talk about everything. Now, so we have the airways, can be divided into two. Here we have the upper airways and here the lower airways. So the upper airways comprise our nose, our mouth, and our pharynx. So here we have the nose, mouth, and the pharynx. The pharynx can also be considered like the throat, like we always say. And the lower part, we have the larynx. We have the trachea, we have the carina, we have our primary, secondary, tertiary bronchi, and we have our respiratory, bronchiole, and then we have our alveoli, which is going to form the alveolar capillary membrane where the gas exchanges are going to happen. So let's start with the upper airway. We have the nose. So the nose have what we call the conchae. They also call the turbinate. So we have three conchae in the nose with their meatus. So the conchaes are gonna help like filter, warm up, and humidify the air that goes into the lungs. And they're gonna do that through the meatus. So underneath the conchae, we have three meatus that also make sure that they create like a turbulent flow so that the air that we inhale is gonna get in contact with the mucosa. So the mucosa are going to filter, warm that air. So this is the main role of the conchae. And also on the nose, our nose can be divided into two parts. We have the upper part and the lower part. The upper medial part is going to be our nasal bone, and the upper lateral part is going to be the maxilla. And the lower medium part is going to be made of like connective tissue, cartilage. We have a dense vascularization at that end. And this is why when people have piercing into their nose, it's very difficult to do like nasal intubation because they can bleed to death. So we always recommend them to remove their piercing before any procedures. So we also have the sinuses in the nose. So we have the frontal sinuses, the maxilla, the sphenoidal sinuses. These are all comprised inside the nose part. Now, the mouth part is going to be our mouth. So our mouth, we're going to see how the mouth helps, because when we get into the lower airway, we have these mucociliary escalator that is comprised of the cilia and the mucus that propels all the germs up to be swallowed into the mouth. So this is how the mouth is involved into the airways. We also have the pharynx. The pharynx, like I said, you can remember it as your throat. It can be divided into three parts. So we're gonna have the nasal pharynx. We're gonna have the oral pharynx, and the laryngopharynx. So I'm gonna try to draw the picture to show you guys how we can limit all these things. So if I have my nose here and I have my mouth comes here and then here. I'm sorry, I'm not the best drawer. So inside my nose, I have these 3 conches here, remember? And also inside the nose, we have the meatus that help the air get in touch with the conches, under the conches, so you can have the warm filter and humidify air into your lung. So your nasopharynx is gonna go from this inferior conche, because this is the superior, medial, inferior, to your soft palate. So if you look at your anatomy of the face here, you have your hard palate that continue here with your soft palate. So from here to the soft palate, from the inferior conche to the soft palate, this is gonna be your nasopharynx. So the nasopharynx is also gonna have the pharyngeal tonsil, which is also gonna help fight the germs. And inside the nasopharynx here, when you have this demarcation here, you have this 90-degree angle here. This 90-degree angle is also part of the nasopharynx. It's also gonna help you trap the germs. Now moving to the nasopharynx, one more thing about the nasopharynx. The nasopharynx communicate with our middle ears. So at one part of the nasopharynx, you're gonna have this eustachian tube coming from the middle ear, and that's how you can get an otitis, a medial otitis, otitis media, if you have an infection going up into your nasopharynx. So very important. Now let's move on to the oropharynx. So the oropharynx is going to continue with your nasopharynx until the base of your tongue, until here. Let me use a different color. So soft palate to the base of your tongue here is going to be your oropharynx. And the base of your tongue here, we have a bone here there that we call the airway bone. Very important. It's located between C2, C3, cervical. Very important. We're going to talk about this. So your oropharynx goes from your soft palate into your airway bone, the base of your tongue, and it contains the palatine tonsil and your lingual tonsil. So these palatine and lingual tonsil also help trap some of the germ and fight the infection before the air even gets into the lungs. So after the oropharynx, we have the laryngopharynx. So the laryngopharynx is going to go from your airway bone, C2, C3, to C6 here, and the C6 is gonna be your cricoid cartilage. So this is where your laryngopharynx is gonna go, from your airway bone to your cricoid cartilage at C6. But now, even when I was studying, I had this confusion part, because your laryngopharynx has the same delimitation with your larynx, which is your lower airways. So your lower airways start with the larynx, and the larynx is also between the airway bone and your cricoid cartilage. So this end of the pharynx and the larynx have the same anatomical delimitation, but functionally they have a different role. So our laryngopharynx, you can see it as your two-way drive, like when you get to a subdivision and you have a left and right branches. So the laryngopharynx is going to give you the demarcation between your digestive tract and your airway tract. So it's going to be this point where it's either the food goes in your esophagus or either it goes to your lungs. So this is how I kind of visualize this, not to get confused. And that is about our upper airway. Now let's go into the lower airway. The lower airway is really interesting. We're going to learn a lot. So the lower airway, like I showed here, is going to be your larynx, your trachea, your carina, your bronchi, your respiratory bronchiole, your alveoli, until the membrane that is going to be responsible of doing the capillary exchange of gases. Now, the larynx, inside the larynx, we're going to talk about many things. We're going to talk about the cartilage. We're going to talk about the muscles and innervation vascularization. Now let's talk about the larynx, the inlet of the larynx. So when you have a patient that you need to intubate and you have a hyperextension of your head, what you're going to see is what I'm going to draw here is the inlet of your larynx right there. That vocal cord entrance is what you're going to see. So first of all, you're going to have your epiglottis here. And then you're going to have your fold here. I'm going to make it better. You're going to have two folds here, which are called airway epiglottic fold. They're going to be there on each side. And then here, you're going to have your arytenoid cartilage. And on top of your arytenoid cartilage, just like corn, you're going to have your corniform cartilage and your cuneiform cartilage. So when you open that mouth wide to try to see the inside of your vocal cord, this is what you're going to see first. You're going to get into your epiglottis. And then you're going to get in your epiglottis on the side to your end. You're going to have the arachnoid cartilage that is a little bit to the back. And you're going to have this fold. Now, inside this fold, if you try to open the mouth a little bit more closer, you're going to have the vestibular fold here on each side. Vestibular folds. And when you pass the vestibular fold, that's where you have the true vocal cord here. That's where you get your true vocal cord. And then there is the opening here in between the true vocal cord that is called the rima glottis. The rima glottis. And the combination of this true vocal cord and the rima glottis is going to give you your glottis. So this is the laryngeal inlet. Like when you open the mouth, this is what you're going to see. You're going to see the epiglottis, and behind there, you're going to see these cartilages here. You will see the epiglottis fold, and then you're going to see the vestibular fold, which is also called the false vocal cords fold. And then after that, you're going to see the true vocal cord, and the opening between the true vocal cord is going to give you the rhimaglottides. Combination of true vocal cord and rhimaglottides is going to give you your glottis, still part of your larynx. Now the glottis can move. The glottis can open and it can close, and it has to do that, right? So the muscle, there are two muscles that help with the opening and the closure of the glottis. So we have the posterior cricoarytenoid muscle and the anterior lateral cricoarytenoid muscle. So these are the two muscles that is going to open and close this true vocal cord. So the posterior cricoarytenoid is going to be the only muscle. It's the only muscle that opens the vocal cord. It's the only opener. It abducts. It abducts, sorry, ABD, abduct. Now your lateral cricoarytenoid is gonna close your vocal cord, but it's not the only one. So lateral cricoarytenoid muscle close the vocal cord. The posterior opens the vocal cord. Now, the attachment of the vocal cord. Anteriorly, here, your vocal cord are going to be attached by the big thyroid cartilage. It's a huge cartilage. They're going to attach anteriorly. And posteriorly, we have this arachnoid cartilage. Posteriorly, that are going to attach. Now, the epiglottis here is like a flap of tissue. It's going to close the vocal cord every time that we want to swallow, so the food don't get into the airways. Now, we have something behind the epiglottis because the root of the tongue is right here. We have the root of the tongue, we have the epiglottis. Inside the fold of the epiglottis like this, we have what we call the vallecula. This vallecula is very important because according to the blade that you use to intubate your patient, you're going to see the role of this vallecula. But for now, remember, when you sleep, you are not constantly swallowing, right? When you sleep, it's not like you are doing, you are not constantly swallowing. So it's because of the vallecula. The vallecula help contain some kind of your speed, so you don't trigger that swallowing reflex all the time when you're sleeping. And it's also is the point that people are going to come in the hospital, like if they have a fishy bones that it got stuck into their throat, it's going to be in the vallecula. So you're going to be able to open the airway and see the vallecula right here. So this is why it's really important. So now let's talk about we saw the attachment of the vocal cord. They are very important. The thyroid cartilage attaches anteriorly, the arachnoid cartilage posteriorly. The posterior cricoarytenoid muscle is the only opener, and the lateral cricoarytenoid closes during phonation, opens during inspiration. Now let's talk about the cartilage. Now that we have like a basic of anatomy, we're going to talk about the cartilages. I'm going to wipe this down. So the larynx have 9 sets of cartilage. So remember, the larynx starts with your hyoid bone here. Hyoid bone, C2, C3. If you come down, you have your epiglottis. C4. Now, behind your epiglottis here, still at the level of C4, but just behind, you're gonna have the thyroid membrane. Now, this membrane is important because this is where the muscle, the arteries and nerves goes and innervate the larynx. We're going to talk about them later. Now, after your epiglottis, you have your thyroid at C5. So the thyroid has like a big membrane which is consistent with the laryngeal prominence, and that is the thyroid cartilage. Is a huge cartilage, laryngeal prominence, and here you have your cricoid cartilage at C6. Now remember, larynx from hyoid bone C2, C3 to C6, and we're gonna have 9 cartilages, but anteriorly your larynx starts with the hyoid bone. Then you have your epiglottis cartilage at the level of C4, which is also the level where you see your thyroid hyoid membrane, where you have your vessels. You also, coming down at C5, you have your thyroid cartilage, which is consistent with your laryngeal prominence, C5, and then you have your cricoid cartilage at C6. So this is the first cartilage, second, third, anteriorly. Now posteriorly, behind this, we have 3 other cartilages that are paired, so they come by 2. So posteriorly, we have the arytenoid cartilage, we have the cuneiform cartilage, and then we have the cuneiform cartilages, and they come into pair 2, 2, 2. So as we saw earlier, remember, the thyroid cartilage is a cartilage that attaches the vocal cord anteriorly. It's a huge cartilage, and it also forms the laryngeal prominence. The arytenoid cartilages that attaches the vocal cord posteriorly. And then we have the cuneiform and the cuneiform cartilage. The cuneiform cartilage helps the epiglottis not to flap down, so it supports the epiglottis. So these are the 9 cartilages of the larynx. So these 3 are anteriorly and they are not paired, and these are paired. So 2, 4, 6, 7, 8, 9. 9 cartilages. Now we're going to talk about the muscles. The muscle of the larynx. So we have the extrinsic and the intrinsic muscle. Extrinsic and the intrinsic muscle. So then extrinsic muscle are the one that help with the swallow. Like when you swallow, they go up and forward to help that spit go inside your esophagus. Your esophagus is behind, so up and forward, they get that spit behind to go inside the esophagus. So extrinsic muscle. And how I remember them is because they are all attached to the hyoid bone. We saw that the larynx starts with the hyoid bone. So they are all attached to that bone. At C2, C3, hyoid bone here. Now we're gonna have those who are superior, like supra-hyoid bone and inferior to the hyoid bone. And how I remember here, we have the jaw. I'm gonna put the jaw here, or the mandible. And here I'm gonna put my styloid process, mastoid process, and here I'm gonna put my omoplate, and here I have my thyroid, and here I have my sternum. So these are all the attachments. So on top here, they're gonna attach to the mandible, styloid process, mastoid process, and down here they're gonna attach to the omoplate, thyroid, and sternum. But their reference is the hyoid bone. So the first muscle upper here is gonna be our stylohyoid muscle. And all these muscles, they do the same function. Don't forget, they help with the swallow. They go up and forward. Now the second muscle is gonna be our milohyoid. Milo is the Greek word of jaw or mandible, and that's how I remember milo. And then we're gonna have a third muscle called the digastric muscle. It's called digastric because it has two parts. The first part is gonna attach to the mastoid process here, and the second part of the same muscle is gonna attach to the jaw. So these two parts are going to form the digastric muscle. And these are the suprahyoid extrinsic muscle of the larynx. Now going down, we have the muscle that are going to attach to your omoplate, your shoulder, your thyroid, and your sternum. Now the muscle that are going to attach to your thyroid is going to be your thyroid or thyroid hyoid muscle. From the thyroid to your hyoid bone, simple. And then you're going to have your sternothyroid. Your sternothyroid. Simple. And then you're gonna have your sternocleidomastoid right here. Your sternocleidomastoid. And then you're gonna have here your omohyoid, omoplate, omohyoid. And these are all your extrinsic muscle. I hope this way is easier to remember. Just remember they are all attached to the hyoid bone, inferiorly to the thyroid, omoplate, and sternum, and superiorly to the mandible, styloid process, and mastoid process. And they all do the same function. They lift up the larynx and forward during swallowing. Now let's talk about the intrinsic muscle. Those muscles that help move the vocal cord, that really helps with the phonation, close the glottis, open the glottis, and all the good stuff. I'm gonna wipe this down. If you like this video, please click on the bell and subscribe. Now, talking about the extrinsic, these are really important. and we already start talking about them. So the intrinsic, sorry, the intrinsic muscle are going to follow the cartilage. So we're going to draw our cartilage the way we did, and from the cartilage, we're going to see all these muscle coming around. So the hyoid bone is on top, and then we have the, remember, epiglottis. That helps. And then after the epiglottis, you have your trachea. After your trachea, you have the cricoid. And behind them, you have the arytenoid. We got two corns, cuneiform, and then you have the cuneiform. Now, it's just gonna follow these patterns, and we're gonna talk about it. First thing first, we're gonna draw the only muscles that opens the airway, and is the posterior cricoarytenoid. Posterior cricoarytenoid. And because it's a posterior, I'm gonna make it dash so that you guys can remember. I'm gonna make it dash. So this is the posterior, the only opener. Open the vocal cord. Don't forget this. If it's the only thing you can take from this video, posterior cricoarytenoid opens the vocal cord. Is now the lateral, same muscle, but the lateral part of that muscle, lateral cricoarytenoid, is going to close the vocal cord. They close the vocal cord. Lateral, they are lateral. They bring the vocal cord together. They close the vocal cord during phonation. Posterior, they open during inspiration. Please don't forget about this. Very important. Now, the arachnoid muscle has two parts. We have the oblique and the transverse. So here we have the oblique arachnoid here. I kind of draw it oblique so it's easier to remember, and then the transverse here. Oblique arachnoid and transverse. And then we're gonna have a muscle here, the aryepiglottic muscle. Aryepiglottic muscle. So the aryepiglottic and the oblique, they are gonna shut down the inlet. Remember I told you about the laryngeal inlet, and we have this aryepiglottic on each side, and then inside we have the vestibular fold, and then inside we have the true vocal cord. So these aryepiglottics, they are gonna shut down. It's like a zip mouth on the vocal cord, and during deglutition. So oblique and aryepiglottics, they're gonna close the vocal cord during the deglutition, so we don't get the food inside the larynx. And the transverse is going to support their action. Now, we have here the cricothyroid. Oh, this is thyroid. My bad. Thyroid. So here we have the cricothyroid muscle. The cricothyroid is a special muscle because it's outside the cartilage, and the implication of the fact that it's the only muscle that is outside the cartilage, it's innervation is going to be different from the others. We're going to talk about the innervation in a moment. So the cricoid thyroid muscle is outside the cartilage, and it's also helped to tense up the vocal cord. It tenses the vocal cord. Now we have the thyroarachnoid muscle. Thyroarachnoid. The thyroarachnoid muscle has a muscle inside called the vocalis muscle that helps relax the vocal cord. Thyroarachnoid, we have a submuscle inside that is called the vocalis muscle that helps relax. And the thyroepiglottis muscle here, thyroepiglottis, the thyroepiglottis is gonna help widen the laryngeal inlet. Remember, we saw the laryngeal inlet, so it's gonna help widen that inlet, and it's the thyroepiglottis. And these are your intrinsic muscle. Very easy, right? So it follows the cartilage. You have your epiglottis cartilage, your thyroid cartilage, your cricoid cartilage, and you have your arachnoid cartilage behind. Now the muscle follows the cartilage. You have the cricoarachnoid, the posterior cricoarachnoid opens, the only opener, and the lateral cricoarachnoid closes. The transverse oblique arachnoid with the airway epiglottis, they're gonna help shut down the vocal cord during deglutition. Thyroepiglottis widen the inlet. Cricothyroid, the only muscle that is outside and is gonna tense up the vocal cord. The thyroarachnoid has the vocalis muscle that is gonna help relax the vocal cord. And I hope this was helpful. Now let's talk about the innervation. The innervation of the vocal cord is going to be done by two main nerves. We have the superior laryngeal nerve and the recurrent laryngeal. Now, the recurrent laryngeal nerve is going to be responsible of the motor innervation of all this muscle except the cricothyroid. Remember, it's the only muscle outside of the cartilage, so it's not going to receive its innervation from the recurrent laryngeal. So recurrent laryngeal, all this muscle except this cricothyroid, the tensor, is going to be outside of the cartilage. Its motor innervation is going to be done by the external branch of the superior laryngeal. Cricothyroid, external branch of the superior laryngeal nerve, that's where he gets its motor innervation. But all the rest of the intrinsic muscle get their innervation from the recurrent laryngeal nerve. Now, the sensory innervation is going to be done by the superior laryngeal nerve. The external branch of this superior laryngeal nerve is going to be the one responsible of the cricothyroid motor innervation. I know it's kind of like confusing, and that's why I extend on it. So recurrent laryngeal nerve, motor innervation of all this intrinsic muscle except the one that is outside the cartilage, the cricothyroid. And because he's not getting his motor innervation from this, he's going to get his motor innervation from the superior laryngeal nerve, the external branch. Now, the superior laryngeal nerve is going to be responsible of the innervation of the superior part of the larynx and the half superior part of the vocal cord. This sensory, superior sensory innervation of the superior part of the larynx and the superior half of the vocal cord. Now, the inferior part of the larynx and the inferior part of the vocal cord is going to be sensory innervated by the recurrent laryngeal nerve. So I'm gonna I'm gonna write it down, because even me, when I was studying, it was like kind of confusing. So, but this is easy. So superior laryngeal innervate the superior part of the larynx, and the superior half of the vocal cord. And this is the sensory innervation. Now, that superior larynx also has an external branch that is going to innervate the cricothyroid motor innervation. And it's also going to do the motor innervation of cricothyroid. Now, the recurrent laryngeal nerve here, I'm going to put him here. Here, the recurrent laryngeal is going to do the motor innervation of all this. Motor innervation, except the cricothyroid muscle. And we see that that motor innervation of the cricothyroid is going to be done by the superior laryngeal nerve, the external branch. And it's also going to do the lower part of this too, the lower part of the larynx, lower part of the larynx. And this is going to be their sensory innervation, and the lower inferior part of the true vocal cord. Sensory. And they are both coming from the vagus nerve. So yeah, this is how the innervation is gonna be done. I know it's a little bit confusing, but it's worth knowing. Superior laryngeal sensory innervation of the superior larynx, superior half of the vocal cord, and it's going to do the motor innervation of cricothyroid. And the recurrent laryngeal nerve is going to do the motor part of all these muscles except him. And it's going to do the sensory innervation of the lower part of the larynx and the lower part of the vocal cords. And this is what I got for the innervation. Now let's talk about the vascularization, which is the easiest. So vascularization is going to come from the subclavian and the external carotid. The external carotid is going to give the superior laryngeal artery, external carotid, superior laryngeal artery, and superior thyroid artery. And the subclavian is going to give us this inferior laryngeal artery and inferior thyroid artery. And they're going to provide the vascularization of the superior and inferior part of the larynx, superior and inferior part of your thyroid. Very easy and simple. Now that we saw the larynx in all his parts, let's talk about, before we get into the trachea, I want to talk about the thoracic cages and the ribs and the sternum. I figure out that this is something that I don't want you guys to miss because it's really important. Now let's talk about the sternum. The sternum is made from the manubrium, we have the sternal angle here, The sternal angle divide the manubrium from the body of the sternum. So here we have the body of the sternum. And then we have the xiphoid process. So this is our sternum. Before we get into the sternum, the upper part of the sternum, which is the manubrium, we have the suprasternal notch, and it's right here. Right here, you can feel it between your clavicles. It's called the suprasternal notch, which is also called your jugular notch. And why am I talking about this? This suprasternal notch is at the level of your T2 vertebrae. And this is where you want your ET tube to end. Like when you put the ET tube, you intubate your patient, it's at this point that ET tube should stop. And we also said it's at 5 to 7 centimeters above your carina. So where is your carina? Your carina is here at the sternal angle. This is your carina, and is at about T5. So this is the midpoint of your trachea, T2. And it's also at that midpoint of your trachea that you want your ET tube to end when you intubate your patient. And it's called the suprasternal notch. Supra, before your sternum, suprasternal. And then when you get into your sternum, you pass the upper part, you have this sternal angle, which is also the level of the carina, T5. And the carina is the level where you have your main bronchi subdivision, the right and the left main bronchi. And this carina, which is the level of the sternal angle, is where your trachea ends. Your trachea, remember, goes from C6 through T5. The upper part of your trachea, C6, is where your cricoid cartilage on your larynx was. Remember, we say that the larynx goes from C2, C3, which is your hyoid bone, to your cricoid cartilage, which is C6. And this is where your larynx ends. When your larynx ends at C6, that's where your trachea starts. Your trachea starts at C6 and go until T5. T2, the midpoint of your trachea, is your suprasternal notch, and that's where you want your ET tube to end. It's 5 to 7 centimeters above your carina. Your carina is at T5, which is the link to the sternal angle between the manubrium and the body of the sternum. It's very important, right? Because we're gonna be airway expert. Now that we know about this, let's talk about the movement of your rib during the inspiration and all that. So during the inspiration, your diaphragm works during inspiration and expiration. So during inspiration, when you get the air in, your diaphragm is going to go down so that it makes more room for your cage, and your external costal muscle are going to lift up to make more room. You can look at me like when I lift up, I make more room, and this is what your external costal muscle are going to be doing. So during your inspiration, your diaphragm, your main muscle of the respiration, go down, and your external costal muscle, they go up to lift up. And then if you do a forced inspiration, you have your sternocleidomastoid and your scalene that are also going to go up to expand. So sternocleidomuscle and your scalene. These are going to be your muscle, your inspiratory muscle. Now during the expiration, your diaphragm is going to go up to push that air out. Expiration. Your diaphragm goes up. And now your internal, not your external, your internal costal are going to go down to restrict. It's like if they go down, my thoracic cage gets restricted, so the air has to go out. It's like the chemistry, the bore is low, so your pressure is inversely related to the volume. So if you bring it down, you restrict your thoracic and more air goes out. And this is going to be done by your external costal muscle. They go down. And you can also use, like during forced expiration, you can also use your abdominis, like your rectus abdominis and all stuff, and they're gonna help with your expiration. I found that it was like quite important to mention that in the anatomy of the airway. Now let's talk about the trachea. We're gonna briefly talk about the tracheas. The trachea is gonna go from C6, from the end of the cricoid cartilage, to T5. T5 is where your carina starts. So when you have your trachea here and then it divides into the right and left main bronchi, this point is your carina, is where your trachea and carina and is at T5, and your trachea start at C6 until this T5. And remember, you want your ET tube to end at T2, which is the suprajugular, the suprasternal notch or the jugular notch. So your trachea is gonna go from T6 to T5, and is go from 10 to 20 centimeters. So this length here. So this length here is going to be 10 to 20 centimeters. And this diameter here is going to be 12 millimeters. I think this is also important because it can help you know like what size of ET tube you want to get, I guess so. And then you have your carina, you have your bronchi, your respiratory bronchi. Your respiratory bronchi and your alveoli is what we call the respiratory zone, because these are involved into the exchange of gases. But your primary, secondary, and tertiary bronchi from your trachea is called your conducting zone. Conducting zone, and this is where you have the shunt, is called the, you have ventilation but you don't have perfusion, right? So, and I will make a video about the shunt and versus dead space. I will talk about it. But your conducting zone, you have a dead space. So dead space is your conducting zone. Conducting zone, you have your anatomical dead space. Anatomical dead space, because here you have the passage of the air, but you don't have any blood bringing the gas. So you have the air plus gas, no. And then your respiratory zone here is where you have the gas exchange. So guys, this is what I have for the airway anatomy. If you like it, please subscribe, share, and put a comment below. And I wish you guys happy Halloween, and see you on my next videos. Thank you.